Hello, this is Hansen. In this brief video, I'm going to review the birth asphyxia quality indicator for the 10 for 2030 quality dashboard, including the background and the actual indicator itself. By way of background, birth asphyxia, which is also known as hypoxic ischemic encephalopathy, or HIE, is one of our most important quality indicators. 90% of HIE cases occur in low and middle income countries, and HIE can result in lifelong neurodevelopmental disability. I increasingly have grown to believe the adage that we cannot improve what we do not measure. And so this quality indicator is very, very important to the long-term outcomes of our newborns. The diagnosis of HIE, as used to determine need for postnatal treatment, is based on having a sentinel intrapartum event, such as a cord prolapse, evidence of intrapartum distress, such as a non-reassuring fetal heart rate tracing or certain characteristics on a cord gas, evidence of perinatal depression, such as a 10-minute APGAR score less than or equal to 5, or certain parameters on a baby's gas taken within the first hour after birth, and neonatal encephalopathy by physical exam, plus or minus an EEG. Being able to measure all of these characteristics are important for a clinical trial, but for the purpose of a quality indicator, we chose the 10-minute APGAR score as a simple and important indicator for a patient being at risk for HIE. The treatment of hypothermia focuses on the fact that a baby experiences brain injury and then reperfusion, after which there is a brief latency phase and then a secondary energy failure. Therapeutic hypothermia has become the standard of care in high-income settings. Therapeutic hypothermia decreases cellular metabolic demand during the reperfusion phase to limit secondary energy failure. It must be implemented within 6 hours of the injury to be effective, so it really only works if there's a true perinatal insult. What is the role of therapeutic hypothermia in the low and middle income setting? The HELIX trial, published in The Lancet in 2021, was the first large-scale trial of therapeutic hypothermia in the low and middle income setting. It was studied in 3 countries in South Asia. The results were both surprising and disappointing. Rates of death were higher in patients who were cooled, and they had no improvement in outcomes of survivors. To be more specific, 408 patients were randomized to either be cooled or receive standard of care. 42% died in the cooling group, of whom 35% died while still in the hospital. This was significantly higher than 31% who died in the non-cooled group, of whom 23% were still in the hospital. This is thought to be due to a more subacute nature of the brain injury and a more heterogeneous etiology of the HIE. Therapeutic hypothermia is a high-risk intervention that requires sedation and therefore risks respiratory failure, bradycardia, hypotension, coagulopathy, and feeding intolerance. With increased risk and decreased benefit, it is currently not recommended to provide therapeutic hypothermia in the low and middle income setting. We move from treatment to minimizing ongoing injury for patients in low and middle income settings with hypoxic ischemic encephalopathy. This starts with optimal labor and delivery practice to minimize fetal exposure to hypoxia and ischemia, effective neonatal resuscitation with a focus on effective bag-max ventilation, meticulous attention to supportive care, including avoidance of hyperthermia, hyperoxia, hypocarbia, hypoglycemia, and appropriate seizure management. These remain the most important steps to reduce brain injury. Of note, in the HELIX trial, all of the babies who had a measured temperature over 38 degrees Celsius either died or had moderate to severe disability. It is because of the recommendation to avoid hyperthermia to minimize ongoing injury that we have selected this as our quality indicator for neonatal asphyxia. The mechanism by which hyperthermia causes neuronal injury is well understood in animal models. It is due to a vascular endothelial injury and platelet activation, increased blood-brain barrier permeability, which causes cerebral edema and prevention of cerebral blood flow restoration, an increase in metabolic demand, which causes increased cerebral blood flow and a reperfusion injury, as well as cytokine, free radical, and glutamate release. So this brings us to the neonatal asphyxia quality indicator. As with many others, it is a two-part question. The first part is determining how many babies actually are at risk for having neonatal asphyxia. The question is, was the newborn diagnosed with birth asphyxia, defined as a 10-minute APGAR score less than or equal to 5? The options are yes, no, not documented, or not available. The second part of the question pertains only to those babies who were diagnosed with birth asphyxia to see if they were or were not exposed to neonatal hyperthermia. The question reads, if diagnosed with birth asphyxia, defined as 10-minute APGAR score of less than or equal to 5, did that newborn have a documented temperature of greater than 37.5 degrees Celsius in the first 72 hours of life, with the same options for answers? This question may be confusing because we also have a question about neonatal hypothermia, but this is a question about hyperthermia, which is high risk for exacerbating brain injury in patients with risk of neonatal asphyxia. Thank you very much.